Today I'm going to talk about harnessing neuroimaging to guide our practice in the NICU and in the neurodevelopmental follow-up clinic. For this presentation, I have no conflict of interest. I'm supported by the care and pay program in neuroplasticity, but it's not relevant, and I have no financial conflict of interest to present today. So I'm going to start with a case presentation, and throughout the presentation, I'm going to show lots of cases, lots of patient histories, and how we do neuroprognostication. And especially there's going to be lots of emphasis on neuroimaging modalities to get diagnostic information, but also use it for prognostication. So I'm going to start with a story of one of our babies. This was baby girl L, who was a 38-weeker, a female term infant. Mom's pregnancy was uncomplicated, and she presented with mildly acidotic cord gases. And baby girl L received PPV for 2 minutes, but no chest compressions and no medication requirement. Was doing well initially and was given to mom and started seizing at 10 hours of life. Baby responded very well to phenobarb loading. So because there was no sentinel event, we did extensive infectious, metabolic, and genetic testing on this baby. Just to make sure that there was no other underlying cause. But the NICU stay was otherwise uncomplicated, and the baby was discharged home in the second week of life. The Hine assessment was initially suboptimal, which I'm going to show you in the later slides, but then it's normalized. And the general movement assessments were initially abnormal, but then it also normalized at 3 months of age. So this is how the baby presented initially to our NICU. You can see the seizures coming from the central regions mostly. As I said, there's going to be lots of emphasis on the neuroimaging modalities today. So this was a baby who was presenting with neonatal encephalopathy. And on this image on the left, this DWI scan, diffusion weighted imaging scan, you can see that there was some injury in the deep gray matter structures, mostly in the thalamic region. The T2 was more or less normal, was showing some increased T2 intensities in the white matter regions, but the myelination seemed to be well formed, fully formed, and it seemed to be symmetrical. So we very commonly see these babies who present in the borderline, these babies presenting with some favorable prognostic factors and some unfavorable prognostic factors. And on top of that, there seems to be some deep gray matter injury. So the question then becomes, how should we counsel the parents? What is the likelihood of cerebral palsy development in this baby? What is the likelihood of being ambulatory? What's the likelihood of being verbal and having cognitive delays or post-neonatal epilepsy? So these are the questions that we usually come up with when we're counseling parents. And today I'm going to show you some recent literature on this and how we can use the literature. The outline will be, I'm going to talk about some patterns of term and preterm brain injury in today's presentation. I'm going to give a frame of holistic approach to neuroprognostication in both preterm and term infants. And again, the emphasis will be on neuroimaging modalities, both on cranial ultrasonography and brain MRI that we use very commonly to get the most out of them in the NICU and beyond. So I'm going to first start with neonatal encephalopathy, and I'm going to talk about neurodevelopmental outcome prediction in babies who are presenting with hypoxic ischemic encephalopathy. There's tons of literature on this topic. So there's a research interest, and in many centers, there are ongoing studies, and there are hundreds of published research on this topic. So I try to summarize all this neuroprediction, neuroprognostication research in one slide. So we have some major prognosticators in this population, and the major prognosticators are first the clinical findings, the evolution of neonatal encephalopathy. So if it's improving, then it's a favorable prognostic factor. And in the post-rewarming phase, especially in the post-rewarming phase, if it's still depressed, if it's still moderate to severe, then it's one of the unfavorable prognostic factors. We also get some information from the amplitude integrated EEG, and evolution of the EEG background also gives us some information, which I'm going to show you in the upcoming slides. And the emergence of sleep-wake cycling is also another prognosticator that we can use. So we use the clinical findings, the evolution of the clinical findings, and we use some amplitude integrated EEG data. But there's a special emphasis on the brain MRI as it gives us some domain-specific prognostic information. And looking at the literature, there's also some potential additional prognostic factors that we can use. But again, these are the major prognosticators. And the prognostic markers that I'm going to mention now are just additional potential prognostic factors. And some of them are clinical, such as the 10-minute Apgar score, not in isolation, but in if they're accompanying many of these clinical electrophysiology and neuroimaging findings, it can be an important prognostic marker for us. The seizure burden, many studies are showing that the seizure burden is closely associated with impaired neurodevelopment. Coexisting dysglycemia, it's not just hypoglycemia that may accompany hypoxic ischemic encephalopathy, but also hyperglycemia may coexist in babies with neonatal encephalopathy and impact the outcomes. And refractory hemodynamic instability, so multi-organ involvement, and especially its accompanying refractory hemodynamic instability, it can be used as an additional prognostic factor. So this is a list of the markers that we use, and I'm going to show you some examples of how we implement them to our clinical practice. So the first list was a list from the neonatal period that we use, but early in the infancy, there are also some other prognostic factors that we use, and one of them is the Hammersmith Infant Neurological Examination. This baby was a term infant who presented with HIE, and you can see that this baby is presenting with diffuse bilateral white matter injury. So all the bright areas you're seeing are diffusion restrictions representing ischemic areas. And you can also see some injury in the posterior limb of the internal capsule, which is one of the major sites of corticospinal tracts. And you can also see some diffusion restriction in the cerebral peduncles of this baby. So again, in summary, this baby is presenting with diffuse bilateral extensive white matter injury, but also there is some injury in the deep gray matter tissues, which seems to be involving the corticospinal tracts. So when this baby presented in the early infancy period at 4 months, so this is us doing the neurological exam with Hammersmith Infant Neurological Assessments. And even by looking at the video, you can see that this baby is presenting with significant tightness of the both lower and the upper extremities. So by looking at the video, we can say that this baby is stiff in all 4 extremities. This baby had a Heinz score of 42, and plotting it on the chart gave us a high sensitivity and specificity for abnormal motor development. And looking at the literature, using Heinz, if we get a Heinz score below 40, it also gives us some information about being ambulatory in the childhood period. And this baby was very close to the threshold and later developed cerebral palsy. And another early infancy prognostic factor is the general movement assessment. Babies with hypoxic ischemic encephalopathy, they almost always present with abnormal GM assessment. That's poor repertoire that we see early in the course. But then if it normalizes, it is one of the favorable prognostic motor factors that we consider. And if the poor repertoire persists, and especially in the fidgety phase, if it's accompanied by cramp synchronized movements, then it tells us that the baby is at highly likely category to develop cerebral palsy. So it's not just some of the neuroimaging clinical and electrophysiology criteria that we use in the neonatal period, but also some other assessment tools, such as the Hammersmith Infant Neurological Assessment Tool and the GM assessments that we also consider to do a better prognostication in these babies. For GM assessment, we do lots of visual assessments, and these are all very subjective, and there's lots of machine learning studies that are ongoing to get more prognostic information out of the GM assessments. And GM can give us further information about even the minor neurologic deficits if we use motor optimality score effectively. So here I'm going to give you an example of a term infant who presented with a moderate encephalopathy. And as you can see here, the baby was presenting with metabolic acidosis. The Apgar scores were low, 1, 4, and 5 at 1, 5, and 10 minutes. The baby had an uncomplicated course and had no seizures in the NICU period. And in the post-rewarming phase, the SARNAT normalized. So initially it was moderate. And as you may remember from the first slide, normalization in the post-rewarming phase is one of the important favorable clinical factors that we consider. And the Thompson score, many European centers are using Thompson score for inclusion criteria in babies with HIE. Initially, it was 7, but in the post-rewarming phase, it came down to 0. So we have lots of clinical findings here that seems to be improving. So they seem to be favorable prognosticators. And looking at amplitude integrated EEG, as you may remember from the first slide, this is also one of the prognosticators that we use very commonly. And this baby initially presented with a discontinuous normal voltage with a lower margin background below 5 microvolts and an upper margin above 10 microvolts, and it was bilateral. But you can see that in the first 6 hours of life, it showed evolution into continuous normal voltage. So looking at many studies, there's significant research on this topic using electrophysiologic tools to get more prognostic information. Just maybe very simply, we can say that if the background is normalizing in the first 24 hours, it's also one of the favorable prognostic factors that we use. So this baby is presenting with some favorable clinical factors that seem to be improving, and also with a favorable electrophysiology data. And on day 2, we can already see the sleep-wake cycling, which seem to be fully established in this baby. That's also one of the favorable prognostic factors. If we see sleep-wake cycling in the first 48 hours, it's a good prognostic factor that we also use. And NIRS, many centers are effectively using NIRS. And this dashed line is representing the rewarming phase. And in the post-rewarming phase, there was no increase in the perfusion of the brain. You can see the baseline, and there doesn't seem to be any major increase, which also is another finding, another potential prognosticator that we use. But again, the major emphasis will be on neuroimaging factors. And on day 1, we are seeing some slit-like ventricles, which is a very common finding in babies presenting with neonatal encephalopathy, and some increased white matter echogenicities. The brain MRI will give us some further information in the post-rewarming phase, and it's a common practice in many centers to get a brain MRI to get more prognostic information. And the brain MRI was perfectly normal in this baby. You can see the nice symmetrical myelination in the posterior limb of the internal capsule here. The white matter tissues seem to be perfectly normal. The cortical ribboning seem to be preserved. And the diffusion-weighted imaging is not showing us any ischemic areas. So in this baby, we have favorable clinical factors, favorable neurophysiology factors, and favorable neuroimaging factors, all of which leads us to the conclusion that this baby is expected to have favorable prognosis. However, this baby is a term infant who presented with severe HIE and with significant acidosis. This baby's Apgar score at 10 minutes was 0, and this baby developed status epilepticus in the NICU stay and had significant hemodynamic instability requiring multiple anti-seizure medications. The post-rewarming SARNAT score was still severe, and as you may remember, this is one of the prognosticators that we use. The baby presented with a severe encephalopathy, and it was still severe. And the Thompson score only came down to 10, which seems to be also a very high score. This baby didn't have normalization of the AEG backgrounds in the first 24 hours and didn't show any sleep-wake cycling in the first 48 hours, both of which are favorable prognostic factors. And still on day 3, this baby was showing persistent burst suppression pattern, which is a very concerning finding. And already on day 3, we can nicely see the 4-column sign, which seems to be affecting the basal ganglia and thalami regions, and it seems to be severely involved. So in these babies, we also try to get some prognostic information from the HIE and from the NIRS. And the NIRS seems to be showing at least 20% increase from the baseline with the start of rewarming in this baby, which was another unfavorable prognostic factor because it shows us that the brain is under reperfusion. We can nicely see the lactate peak in this baby and the baby's diffusion-weighted imaging. And the correlative imaging, that's the ADC mapping, is showing significantly impacted brain, diffuse bilateral brain injury and also extensive injury in the basal ganglia and thalami regions in the post-rewarming phase. So in a baby who's presenting with this history, we have all the unfavorable prognostic factors from the clinical assessment, from the neurophysiology tools, and from the neuroimaging findings. So in this baby, unfavorable prognosis is expected. And then we need to be more specific about the unfavorable prognosis, and we need to be domain specific. So usually babies with HIE present with one of the three subtypes of injury. They can either present with deep gray matter predominant pattern, in which we see injury in the perirolanthic regions, in the deep gray matter regions, and also in the brainstem if the injury is severe. And in these babies, deficits, neurodevelopmental and neurological deficits usually start early in the infancy. They may present with motor impairments, and namely CP, and they may present with cognitive and language delays, also neurosensory impairments, post-neonatal epilepsy, and the feeding difficulties are also very common in this population. Another subtype of hypoxic ischemic encephalopathy is the white matter watershed predominant pattern, in which we see the injury mostly in the white matter tissues, and those are the watershed areas of the white matter tissues. And these babies, if you follow them until 2 to 3 years of age, which is a very common practice in many North American centers, you may be able to miss a great majority of the problems that these babies will face, because they grow into their deficits and may present with learning issues, some cognitive problems at school age. So usually a great majority of the challenges that these babies may face present at school age. That's one of the important things that we need to remember. Or we can see an injury that's a combination of both of these patterns. So I'm going to present two patients now. These patients are from Dr. Linda DeFries's series, and I find them very useful. So I'm going to show their clinical evolution over the years. This was a term infant who presented with severe HIE. As you can see, the lab criteria was showing severe acidosis, UPGARs were low, and the baby met the criteria for therapeutic hypothermia, had a complicated course requiring multiple inotropes, and developed repetitive seizures requiring multiple anti-seizure medications. So this baby is already showing clinical findings that seems to be unfavorable. This was the AEG on admission, which seems to be showing burst suppression pattern, and the normalization happened on day 7. And as you may remember, a normalization of the background, if it happens in the first 24 hours, that's a favorable prognostic factor. So this is not the case for this baby. The day 3 head ultrasound was showing some increased echogenicity in the white matter tissues, but also some subtle findings in the basal ganglia and thalami region. And as you can see here, this baby is presenting with some deep gray matter nuclei injury in the diffusion-weighted imaging. And the later scan is showing some atrophy of the basal ganglia and thalami regions in this baby. So MRI gives us more information and domain-specific information that we can take into account in these babies. And this baby developed cerebral palsy that was diagnosed in the first year of life. At 24 months, the baby was still age appropriate for the cognitive domain. So you can see that the baby is accomplishing some of the questions that are presented in the Griffiths test. But you can see that at 24 months, the baby is still not ambulatory and showing this abnormal locomotion pattern due to dyskinetic cerebral palsy. At 3 years of age, the baby is still age appropriate from a cognitive perspective, but looking at the posture of the hands, you can see the abnormal posture due to high tone in the distal portion of the upper extremities. At 3 years, this baby is presenting with. Can I ask? Somebody's mic is on. So at 3 years of age, this baby is now ambulatory, and with the help of a posterior rollator, the baby is now actively walking, not independently, but it's a very good sign for the baby. So they continue to explore their environments, which is a good sign for their cognitive development. And at 4 years, with minimal help from the posterior rollator, You can see that the baby is climbing up a hill very nicely. And at 5 years, you may remember that this baby was presenting with deep gray matter injury and developed cerebral palsy as expected, because this was a moderate injury involving around at least 50% of the basal ganglia and thalami region. Is still having some difficulty with the fine motor tasks, as you can see here. But at 5 years, we can see that the baby is now walking independently. Not a baby anymore. This child is walking independently, which is a perfect sign for this baby, because this baby will continue to explore the environment and learn from the environment, which is great for his cognitive skills. And this baby was presenting with the second type of neonatal encephalopathy. Another term infant who presented with HIE, met the criteria for cooling, and developed repetitive seizures and had a complicated NICU stay. On day 1, had ultrasonography, there was some increased echogenicity in the white matter tissues, and the ventricles were slit-like due to the mass effect of the edema in the white matter tissues. And in the post-rewarming phase, the brain MRI was showing, the diffusion-weighted imaging here is showing bilateral diffusion restrictions, but the basal ganglia and thalami region seems to be spared. This baby is presenting with atrophies in the frontal regions. So this baby is consistent with the second type of injury that I showed you. That's the watershed white matter type. So in these babies, motor problems are not likely. They can still be seen, so they need close monitoring. But the most important domain that we need to remember is the learning and cognitive domain that seems to be impacted at around school age. So at 24 months, the baby, this baby is doing really well from a cognitive perspective and is age appropriate. At 24 months, you can see that the baby is ambulatory and from a motor perspective is very age appropriate, kicking a ball, getting the ball from the floor. At 3 years, you can see the cube test is very speedy in accomplishing this test and using both hands alternately. At 4 years, the motor domain still seems to be very age appropriate. And from a cognitive perspective, this baby is still age appropriate. So both motor and the cognitive domain seem to be age appropriate. But then the baby starts to show some problems. And at 7 years, this baby was diagnosed with ADHD at 5 years. And at 7 years, the cognitive score was below -2 standard deviations. So that's a very typical presentation that we see in babies who present with white matter watershed type. So these babies definitely require ongoing monitoring for the cognitive domain until at least around school age. But still, at 7 years, you can see that from a motor perspective, the child is doing really well. A great majority of the babies may present in the gray zone, and in these babies, we need to use the literature very effectively. We need to find similar literature. This was a baby who presented with HIE and was cooled. And the post-rewarming phase brain MRI showed some injury. This is very similar to the first baby's injury pattern, but seems to be more extensive in the basal ganglia and thalami regions, but also in the, you can see that it's also in the thalamic regions. And looking at T1 scan, it was equivocal for the myelination pattern. So to get more prognostic information for babies who are presenting in the gray zone, we need to look at the literature, and there's some published data on these babies as well. So Martinez Biarje from Imperial College, together with her colleagues, published this article, which we use when counseling parents. So they categorize the patients based on their neuroimaging findings into 3 categories. So some will develop only minor injury in their basal ganglia and thalami region, and especially if they present with symmetrical myelination in their posterior limb of internal capsule, we can be cautiously optimistic in these babies, and all expected to walk at around 2 years or before 2 years. And there's only marginally increased risk of neurodevelopmental impairment, and this is mostly due to the history of HIE in these babies. If babies present with basal ganglia and thalami region injury, which seems to be less than 50% of the basal ganglia and thalami region, then we need to pay specific attention to the plic region to see how the myelination is. And as you can see in this baby, some babies may present with equivocal plic myelination, and this may affect the outcomes. And these babies are likely to develop cerebral palsy, but CP in these babies are mostly mild, and more than 2/3 of these babies can become ambulatory. Their cognitive and language domains should also be monitored very closely. And proportionate to the amount of injury in the basal ganglia and thalami regions, these babies may also present with feeding issues. So we need to pay specific attention to other domains as well. If the babies present with extensive basal ganglia and thalami injury, which occupies more than 50% of their deep gray matter structures, and especially if the myelination pattern is abnormal, as you can see here in this baby, then they are highly likely to develop cerebral palsy. And most of the CPs that these babies develop will be severe cerebral palsy and higher grades of GMFCS levels. These babies are also at risk of developing cognitive and language delays, and feeding problems are more commonly seen in this population. And all of these information are very important when we're counseling parents. To get more prognostic information, we sometimes use scoring systems. And for HIE scoring, there are many developed scoring systems. And one scoring system that we use for the clinical purposes, not just for research, but also for the clinical purposes very routinely, is the Weike scoring that was developed in Utrecht University by Lauren Weike and her colleagues. And studies are showing that if we use scoring systems effectively, then we can get more information about the motor development, but also for the cognitive and language development until around school age. So using standardized scoring systems may improve our predictive ability as well. A commonly asked question is, we put a lot of emphasis on brain MRI, but can we also use cranial ultrasonography for prognostication? Brain MRI is readily available in many centers, especially in Europe and in North America. But if brain MRI is not readily available, then we can also use cranial ultrasonography to get some prognostic information from that. There are many cranial ultrasound-based scoring systems. The first two that were developed by Leiser and Zwarte, they didn't have separate scoring for the basal ganglia and thalami region. And then the later one that was developed by 10 didn't have predictive values that were reported. But a more recent one that was also developed at Utrecht University by Kim Anning and colleagues shows us that if we use cranial ultrasonography in a time-based manner, time-sensitive manner, we can also get some prognostic information in these babies. And day one head ultrasonography may not be predictive, but it should be still done because it gives us about the timing, some information about the timing of injury in these babies. So in the first day ultrasonography, if we see ischemic injury already, it tells us that the injury started antenatally. But if you use it in a serial manner, beyond 48 hours of life, its predictive value increases. And if you use a cutoff of 3 with the Anning score, then we can also get some prognostic information. But again, we shouldn't put lots of emphasis on cranial ultrasonography and its prognostic ability. MRI is readily available in most centers, and we can get lots of very valuable domain-specific information from the brain MRI. The head ultrasonography for prognostic purposes should be used if MRI is not readily available in your center. I'm going to switch gears here, and we'll move on to another topic, that's perinatal stroke. So very commonly we see babies who present with focal colonic seizures. And in babies with stroke, beautiful studies are showing that there are some major prognosticators that we can use for the motor outcome prediction, but also for the cognitive and speech and language outcome prediction. And for that, the corticospinal tract involvement seems to be a major prognosticator. And if we combine it with standardized motor assessments, such as Hammersmith Infant Neurodevelopmental Assessment, then we can get more prognostic information from the brain MRI. And other domains are, for the other domains, such as the cognitive domain and the language domain, we can use the laterality of the stroke. If it's bilateral, it usually carries a poorer prognosis. Main MCA area involvement usually carries a poor prognosis. I'm going to show you an example of two cases for the main MCA stroke involvement. And the basal ganglia thalami injury is also very critical with this type of brain injury because of the close association of the deep gray matter structures, not only with the motor development, but also with the cognitive development and language and psychosocial development. So this was a term infant who presented with right-sided focal clonic seizures. As you can see in this video, the baby was presenting with a unifocal clonic seizure and was admitted to the NICU. And as soon as we admit these babies, we always get a head ultrasound to see if there's any major problem inside the brain. Of course, the brain MRI is more detailed, but as a preliminary tool, the head ultrasonography gives us lots of information. And in this baby, we were able to obtain some data from the head ultrasonography, and we were able to see the increased echogenicity that seems to be asymmetrical between the right and the left sides. And this was highly suggestive of a stroke event in this baby. Next day, the baby had a brain MRI, which confirmed the diagnosis of stroke. You can see the MCA involvement, and it seems to be a complete MCA involvement together with the involvement of the basal ganglia and thalami regions. And you can also see some involvement diffusion restriction also in the cerebral peduncle. We were also able to see the thrombus that rarely happens in babies with stroke. And the MR angiography confirmed the diagnosis of flow loss in this baby. As you can see, the MCA on the right side seems to be intact, but we are not able to see the left-sided MCA, which confirmed the diagnosis in this baby. At 3 months, the baby had a repeat scan. This shows us the cystic degeneration of the left side, and you can see the volumetric difference. If you compare the left side and the right side, you can see the asymmetry. And this asymmetry was also true for the cerebral peduncles. If you compare the cerebral peduncle volumes, it seemed to be atrophic on the left side. So again, to do a good prognostication in these babies, we need to look at the literature, and the literature in these babies showing us that main MCA stroke increases this likelihood of cerebral palsy significantly in these babies. And these babies are also at risk of developing cognitive and language problems. And it is also likely, which is seen in more than 50% of the population. And as expected, this baby developed a unilateral spastic CP of the right side of the body. And it was diagnosed early with the implementation of standardized neurological assessment tools. And this was another term infant who presented with right-sided focal clonic seizures. And the baby, after admission, showed a very good response to anti-seizure medications. The NICU stay was not complicated, but later, during childhood, this baby developed epilepsy and required hemispherectomy for epilepsy. You can see that this baby is presenting with a significant asymmetrical echogenicity that is highly suggestive of a unilateral stroke. And this is the most common location of stroke, the left MCA. The day 3 brain MRI showed left MCA stroke, and it was very clear, and it was complete. And you can see that the cerebral peduncle was also involved in this baby. And later, after hemispherectomy, the baby required another brain MRI, and the brain MRI was showing significant volume loss in the left hemispheric structures, as you can see here. And even the asymmetry of the cerebral peduncle and the basal ganglia and thalami region was very evident. And some advanced neuroimaging techniques can also be implemented in these babies. And this diffusion tensor imaging shows us the asymmetry of the corticospinal tracts that seems to be fully formed on the right side, but it seems to be absent on the left side. And also the optic radiations on the right side and on the left side seems to be very asymmetrical. So the GM assessment of this baby showed poor repertoire, which is one of the abnormal patterns that we see commonly in babies who present with stroke. You can see the jittery movements of this baby, mostly on the left side, and the baby was presenting with a poor repertoire pattern, which seems to be concerning. And we didn't see normalization of the fidgety movements in the fidgety phase. At 3 months, this baby was not showing the typical fidgety movements that we expect to see. And you can see some limitation of the activities of the right upper extremity. And as expected, this baby developed cerebral palsy. we were able to implement the neuroimaging tools and some standardized assessments in this baby's neuroprognostication. And as expected from the diffusion tensor imaging, this baby also developed right-sided visual deficits. And in this video, you can see that the baby is presenting with right-sided unilateral cerebral palsy, which is hemiparetic cerebral palsy. And the motor development seems to be impacted. Due to high socioeconomic status of the parents and parental education, the baby was doing well at 3 years from a cognitive and language perspective, but as expected from the neuroimaging analysis and other further early childhood markers, this baby developed CP. So I'm going to switch gears and we'll move on to preterm injury patterns here. And for preterm brain injury prognosticators, there are some very similar to term injury. There's lots of research, and all these research tell us that especially the very preterm population, and particularly in this population, the extremely preterm infants are at high risk of developing neurodevelopmental impairments. And a great majority of these neurodevelopmental impairments may persist into childhood and school age, and also to adulthood to affect the academic performance and their work life. So major prognosticators in these babies are the gestational age. And among all the prognosticators, this one seems to be the single most important prognosticators that we use. So the lower the gestational age, the higher the risk of adverse neurodevelopmental outcomes. But by looking at the characteristics of the brain injury, we also get some information, and I'm going to show you some examples of it. Coexisting morbidities are also important, and especially in the very preterm population, the accompaniment of severe ROP, chronic lung disease, surgical neck, and gram-negative infections increase the likelihood of neurodevelopmental impairment significantly in this population. And also the timing of interventions, both in the NICU period and also in the early childhood period, are very important to get better outcomes. But there are also some potential risk factors which we mostly overlook, but there should be some specific emphasis on some of the potential risk factors as well, such as the socioeconomic status and the parental education. We need to take into account the effect of pain versus pain medications. And an optimal nutrition is also important for a healthy preterm brain growth. And some other factors such as prolonged mechanical ventilation, which seems to be closely associated with adverse outcomes in the preterm population. So if you look at the neuroimaging patterns and correlates in the preterm population, white matter injury, this is the preferred terminology that we use in babies presenting with the ischemic inflammatory type of brain injury. A minority of these babies will present with cystic type. It's luckily in this day and age, it's seen in less than 3% of the very preterm population. But we sometimes see punctate white matter lesions, which is the non-cystic form of white matter injury, preterm white matter injury, and it may also affect the outcomes. And I'm going to show you some examples of how it may impact the outcomes. But sometimes without the accompaniment of a brain injury, a hemorrhagic or an ischemic brain injury, we can sometimes see findings of this maturation in these babies' brain with white matter volume loss or myelination delay with some asymmetrical myelin development. So these are the neuroimaging correlates that we can see in babies, preterm infants with or without brain injury. For head ultrasound is sensitive to the cystic lesions, so we can reliably detect the cystic lesions with head ultrasonography because of its high sensitivity. But for the punctate white matter lesions, its sensitivity is operator dependent and it declines significantly. So we can use it for diagnostic and prognostic purposes in this type of brain injury more effectively than this type of white matter injury. For babies who are presenting with non-cystic type of white matter injury, there's lots of research, very similar to the other patterns of brain injury. But if you make an imaginary line that divides the ventricular line as anterior and posterior portions of the brain, usually if they're large in number, if there are many, and some authors are using number 6 as a cutoff, for the number of these punctate white matter lesions. If they're linear, or if they're grouped together, they increase the risk of neurodevelopmental delays, both for cognitive and the motor domains. The posterior ones are less critical, but if they're especially anteriorly located, if they're larger in number, and if they're grouped together, then the adverse neurodevelopmental outcome risk increases in these babies. But we should remember that MRI has a high specificity, but moderate sensitivity for this type of injury to predict the neurodevelopmental outcomes. And its motor predictive accuracy is higher than the cognitive predictive accuracy. In this population, we also always need to consider the clinical and the sociodemographic factors that I tried to present in the previous slide. And these are also going to be important neuroprognosticators for us. This baby was another baby from Dr. DeFries's series, and a relatively larger infant, a 33-weeker, who had an uncomplicated birth, but presented with seizures on day one, and then went on to develop status epilepticus and required multiple anti-seizure medications. The NICU stay was also complicated by infections. The early head ultrasound, as you can see here, is showing asymmetrical heterogeneous white matter echogenicity. In these babies, we continue to do head ultrasonography in a serial manner, and usually 2 to 6 weeks after the onset of these increased echogenicities, if they don't disappear, they may develop into cystic lesions in a minority of the patients, and this baby developed cystic white matter injury. And the term MRI, term equivalent HMRI, confirmed the large cystic lesions that seems to be in the centrum semi-ovale region of this brain. So babies, if they're small preterm infants, and especially if they present with this type of white matter injury, cystic type of white matter injury, looking at the literature, there's an increased risk of developing motor impairments and also neurosensory problems, which this baby did. And already at 6 months, this baby was diagnosed with cerebral palsy. And at 9 months, you can see the suboptimal motor outcome and all the signs of spastic diplegia. At 3 years, this child was still not ambulatory, and you can see, even by looking at the video, the increased tonus of the lower extremities, the scissoring phenomenon that we are able to see in the lower extremities. And as expected, this baby also presented with some neurosensory deficits, was diagnosed with CVI, as you can see, is holding the objects close to the eyes, and cognitive impairments was significant for this baby, together with the fine motor impairments. And if the injury is hemorrhagic type, with the low-grade IVH, we expect to see favorable outcomes for the most part. There's some controversial literature also on that. But clinically speaking, if the babies are presenting with low-grade IVH, unless there is accompanying white matter injury, outcomes are usually favorable in this population, but they require ongoing monitoring. With high-grade IVH, adverse outcomes become likely, and it is affected by multiple factors. And again, for this type of brain injury, there's lots of literature. And if we focus on the early childhood within the first 4 years, the degree of prematurity is an important prognosticator that we need to use. The grade of IVH, so the higher the grade, the more likely the adverse outcomes. Coexisting white matter injury is also important in these babies. The development of a post-hemorrhagic ventricular dilatation, and especially those who require ventricular peritoneal shunt, will require ongoing monitoring due to the risk of adverse neurodevelopmental outcomes. And the timing of interventions, and especially the interventions for hydrocephalus that start in the antenatal period, may affect the prognosis for these babies. At school age, these babies will remain at higher risk of cognitive and psychosocial problems. Two important determinants of neuroprognostication in this population will be the degree of prematurity and the severity of IVH. And at school age and after school age, at adolescence and adulthood, these babies may present with learning problems and memory problems. And two important modifiers seem to be the maternal education and socioeconomic status of the parents. As you may recognize, these two modifiers seem to be important in most types of injury that we see in the preterm and in the term brain. This was a extremely preterm infant who we admitted to our NICU, who had a very complicated stay and had lots of issues, especially with respiratory problems and hemodynamic instability. The baby, as expected, developed a hemorrhagic injury and developed post-hemorrhagic ventricular dilatation, which was also complicated by periventricular hemorrhagic infarction. At 1 month, you can see that the early MRI is already showing the porencephalic cyst, which seems to be very large on the left side, but the ventricles are also large. This baby required lots of interventions, but the interventions started once the baby was above the red line, which seems to be the critical region. At 3 months, this baby showed some improvement of the hydrocephalus, but also it still seems to be large. And you can see the cross-cerebellar diaschisis, which seems to be impacting the opposite side of the cerebellum due to loss of input. And at 18 months, it becomes even more clear that the more affected supratentorial region affects the opposite side of the infratentorial region. As expected, this baby developed cerebral palsy and was diagnosed with cerebral palsy at 8 months of age. It was involving all 4 extremities, but more prominent on the right side of the body. And by looking at this abnormal locomotion at 3 years, the baby is still not ambulatory and developed global developmental delay and was not testable for the cognitive and the language domains. For this type of injury, we can also use some standardized scoring systems, very similar to HIE. There are developed scoring systems, and Kidokoro is the one that we use for the preterm brain injury patterns. And by looking at the cystic lesions, evolution of the hemorrhagic lesions, we can get lots of prognostic information. So a couple of slides on where this is evolving to, and I think I put lots of emphasis on neuroimaging modalities, some neuroimaging neurophysiology tools, and some early childhood markers such as the GM assessments and the standardized neurological assessment tools. But with the help of large databases, omics, genomics, proteomics seems to be the next frontier, and especially by implementing the machine learning, we can get more prognostic information for these infants, which will help with the precision medicine. And there are beautiful studies by Maria Luisa Tatarano's group on using precision medicine for neuroprognostication. And a very recent article is also showing that we can use electrophysiology tools to get more prognostic information if we combine it with machine learning. So I would highly recommend reading these articles to get further information. And in the future, with the help of deep machine learning, we will get more diagnostic data from all these artificial neural networks, and we will do severity grading much better, and we will get more prognostic information in these babies. So in summary, prognostication is bringing all the pieces together when the babies are in the NICU and early in the course, when the babies start coming to our neurodevelopmental follow-up clinics. And we should always consider the clinical risk factors. There's a lot of emphasis on neuroimaging, but we should also consider the clinical findings, and especially the evolution of the clinical findings, and some environmental factors are also important for us to be able to do a better prognostication. Neurological exam is very important, and especially doing it in a serial manner will give us more information. Using neurophysiology tools and neuroimaging more efficiently will give us further guidance in babies who are presenting with both preterm and term patterns of injury. We should always choose objective assessments over the subjective reviews, which will give us more prognostic information. And these information will be more reliable for us when we're sitting down together with the parents. And we need to do long-term follow-up for all these babies who are presenting with brain injury with standardized tests in the long term. So I will finish with the first patient I presented. You may remember baby girl L. This baby presented with some deep gray matter injury, which seems to be affecting less than 50% of the basal ganglion thalami region, and it seems to be mostly located in the thalamic region. And in this baby, the myelination seemed to be reassuring because it was symmetrical and fully formed for a term infant. At 4 months, baby girl L had increased lower extremity tone, and this was something we were anticipating. And the baby's hind score was suboptimal. So we did some developmental coaching for this baby. And then at 4 months, our assessment showed us that the baby was, from a gross motor perspective, was mildly delayed. So we started early interventions. Occupational and physiotherapy services started in a timely manner for this baby. And at 18 and 12 months, neurological exam normalized. We didn't see any hypertonicity in the lower extremities anymore. The gross motor skills were still mildly delayed, and we continued occupational and physiotherapy services for this baby. And at 18 months, we did a Bailey assessment for this baby, which seemed to be showing some suboptimal cognitive and language scores. But the baby was independently walking as expected. The motor development was age appropriate. So we continued all the interventions, and especially we focused more on the speech and language and the cognitive outcomes in this baby. And at 3 years, when we last saw this baby, you can see that the motor domain seems to be very age appropriate. The baby was jumping up and down, was playing with the ball very appropriately. Both the gross and the fine motor skills seem to be very age appropriate. And if you look at the cognitive and the language domains of the Bailey test, the child did really well within the age appropriate range. But of course, we'll require further monitoring until at least around school age. But we were able to see some reassuring findings. I would like to stop here for questions, and I would like to thank you for your attention.